letting me speak about this topic that's near and dear to my heart. Thank you for the introduction, and thank you for listening. We're going to talk about inherited predisposition to melanoma, things that I am excited to see as an emerging field and continuing to enhance within the melanoma community. And so I want to explain a little bit more about that. When I talk about inherited predisposition, these are genetic changes that we inherit from our parents that a change that may be in every cell of our body that can increase our risk potentially for cancer and melanoma in specific. So that's sort of the introduction. These are my disclosures. What are we going to talk about in specific today? So I'm going to go a little bit in sort of a history time warp, going back about 200 years. We're going to talk about the first description of inherited predisposition to melanoma. I'm going to explain a little bit why I think it's important. Then we're going to take a step back and talk about what is genetic testing. What does that mean when we're talking about how do we decide who has inherited predisposition to melanoma? Then we're going to step forward to the last 10 or so years in terms of the advances that have been made in terms of the genetic information that we can tap into. And then the last part of the conversation will be, where do we go from here? How can we enhance what we've already done? So I was a history major in college, so I will always go to the history, as I mentioned. We're going to go back about 200 years, and what you can see in the red box, but also throughout this text from Dr. Norris, I have no idea who he is, but thank you, is that he was describing a family of individuals who developed melanoma, multiple individuals in the family that developed melanoma, along with what seems to be atypical mole syndrome. You can see that they had many moles. Side point that's very interesting, it seems like 2 of the family members developed melanoma in the same exact location on their body. We won't go into that. But I think what is critical to see is that the understanding of an inherited predisposition to melanoma before we really understood genetics predated a lot of our conversation about melanoma risk. And so that indicates that it was fairly evident to some people that there was a familial component to this cancer. So I say we lived in the genetic wilderness for about 175 years, where we had not yet pinpointed what were some of those genetic risk factors. What I'm showing on the screen here is a pedigree of a very high-risk melanoma family. The black boxes and the black circles are individuals that had developed melanoma, so you can see a lot of people in this family had melanoma. And this was the focus within the hereditary melanoma community, was looking for these families and establishing what genetic risk factors are present. This was the first description of a gene called CDKN2A with regards to inherited predisposition to melanoma, which markedly increases your risk for melanoma. We see multiple melanomas in the family along with pancreatic cancer. And that's what we focused on, along with CDK4, which was in the same pathway as CDKN2A, and the loss of function of these of CDKN2A would increase your risk for melanoma markedly. And that's what we talked about for a long period of time, because that's what we thought hereditary melanoma was. It was pretty rare in the melanoma community. But I would take a step back and just say, as a side point, if we think about melanoma as being maybe 2 to 3% of the population, even if something is genetic, you may not see it as strongly in a family as we see here. So I think that's just important to keep in the back of your mind. So I'm going to take a sidebar here, maybe be a little bit controversial, but I think it's important to contextualize how we're thinking about inherited predisposition to melanoma and why maybe we haven't put as much focus, I'll make the pun, we'll shine a little bit of light on sun exposure with regards to melanoma risk. So this is the interactive portion of the talk. I do want to get sort of a show of hands, but before we do that, I want to stipulate that when I'm talking about sun exposure, I'm not talking about tanning bed exposure, which we'll talk about in a second, but specifically, I want to talk about sunburns, and this is primarily for cutaneous melanoma, I should also mention, sunburns in childhood and early adulthood, which is where we see sun exposure as relevant for melanoma risk, not chronic sun exposure, so I want to stipulate that. And so what I would like to do is sort of get a show of hands. I'm going to contextualize it with certain other cancers. So for those who want to say twofold, that's about esophageal cancer and hot tea. There was a recent study that if you drink, I guess, a lot of hot tea, maybe you double your risk of esophageal cancer. So how many people want to raise for twofold? Okay. Let's go to threefold. Fivefold, that's asbestos and mesothelioma. Okay. Tenfold. And then we'll go to 20-fold, that's about smoking and lung cancer. And then we'll say some people didn't answer, but thank you. Okay. So the joke that I make is that I will continue to put this slide in my talk until we get the majority of the room giving the answer that I would say is supported in the literature. And so that's the answer that is up there. Germline genetics is the study of those genetic changes that are inherited throughout all of our entire body. And so we'll talk, so that's why, I'll take a step back and slow down. So I want to explain why I study germline genetics and why I think it's important for the melanoma community. Sun exposure is about 2 to 3-fold increased risk for melanoma. Tanning bed exposure is about 2-fold, depending on the study. So I think that's important. The other thing that I would say as a side point, why I think it's interesting, is that we talk about lung cancer and smoking. Depending on how much and how long you've smoked, you can increase your risk maybe 10, 20, 30, 40-fold with lung cancer. And yet there are many lung cancer cases that have nothing to do with smoking. So I would say we can sometimes perhaps flip this in our understanding with regards to melanoma, that there may be melanomas in classically sun-exposed areas that may have less to do with sun exposure than we once thought. But I think the kicker is this twin study that I would like to talk about. And so what they do in these twin studies is they compare rates of different diseases. In this situation, it's cancer. And they want to understand if one twin has a cancer, what is the odds of the other twin getting a cancer? Not odds, what happened? And so they compare identical twins, which essentially have the same genetic material, and then fraternal twins or dizygotic twins, which have sort of genetic material like siblings. And so what the question there is, the assumption is that the environmental risk factors will be reasonably well shared across different types of twins, but the genetics are obviously closely aligned in identical twins versus less closely aligned in fraternal twins. And so I clearly am highlighting what I want to show in the red box there, but what is critical is that melanoma actually came out in this analysis about 10 years ago in the Journal of American Medical Association, is that it was the most heritable cancer of all those studies, higher than classically thought to be inherited breast, ovarian, and colon cancer. And so, and I'm not going to comment about the shared environment, sort of that big zero there. I'm not sure what that means, because this is not my area of research in terms of this kind of study. But I think it's critical to understand that it may be more heritable than we think. And the one other side point that I will make is that we talk a lot about risk factors for screening for melanoma, for cutaneous melanoma. We talk about fair hair, light eyes, inability to tan, many moles. All of these are genetically predisposed. And so I think we need to think about that also. Those are genetic risk factors for melanoma. Okay, so what I've talked about is, hopefully, maybe some of you think that genetics are important for melanoma, but then the question is what do we do about it? How do we test for this inherited predisposition? So essentially, it's a blood test that we take a blood sample, DNA or genetic material is extracted, then it's sent off to a commercial lab where they test for genes that are both related to melanoma, but also general cancer susceptibility. And so what they're looking for there is genes like CDKN2A, which I mentioned earlier is relevant for melanoma, but also BRCA genes, TP53. What we're learning with melanoma and other cancers is that we don't necessarily have to be as specific in our testing panel, because we're not always actually as good at predicting which genes are relevant for which individuals, so we should go broader based. So this is a panel of about 80 or so genes where we're looking for sort of 3 results, essentially. One is a positive result, where you have a genetic change in a cancer susceptibility gene, typically which means that that protein is not functional, all the way to no significant changes. And then in the middle, we have what are called variants of uncertain significance, where the research is still emerging about what that genetic change means for the function of that gene or protein. So what do we learn when we get those results? Why are the positive results so important, both in melanoma but also for other cancers? And so if you test positive for one of those genetic changes, that means that we have guidelines from the genetic community about what cancer screening you should do for which you're higher risk, but also potentially prophylactic measures that can reduce your risk. So for example, well characterized in terms of prophylactic mastectomy for patients that are higher risk for breast cancer. But the intensive screening is also about early detection. And the key for any of this genetic testing is not to give you information that you can't do anything about. It's about that we have then those specific guidelines that then you can use going forward. The other thing that's interesting, and this is more in other cancers rather than melanoma, but we'll talk about that in a second, is that sometimes those genetic changes that are throughout all of our body actually can predict efficacy or enhance efficacy of certain cancer treatments. And so that's critical from the oncology side. And then the last thing is just a practical consideration. If you have a genetic change that puts you at risk, likely someone in your family will, and they can get tested even before they have cancer, and then that can guide them for those aggressive screening methods and or prophylactic measures to reduce the risk of cancer or detect it earlier. So I'm saying a lot of things that sound good, but why don't we do genetic testing for a lot of people? So I'll try to be reasonably fair. There are downsides of genetic testing. One, which has been a big factor, has been cost. It used to be thousands of dollars to test genetics for one gene, the genetic changes for one gene. That has come down significantly. The panel-based testing that I was mentioning is now several $100s, so it's much easier to test more genes. So that sort of has come down, but it's still a factor. I think a critical point is that a lot of people do not want to know because they will be anxious about that information. So for some people, this is not the right choice. I don't think we should give added anxiety for someone, so sometimes that information is not powerful for them. The other thing is that some of these patients, while they may be super high risk to develop a cancer, they may not develop a cancer. And so there are risks associated with that screening and potentially those prophylactic measures that may not be balanced out necessarily because they may not have gotten cancer. So that's a factor as well. And then the final thing, which is just a practical consideration, is that if you test positive for one of these genetic changes, it can affect your life insurance. So what we practically often tell people to do is get life insurance in place, then get genetic testing, and then it shouldn't be an issue. So now let's bring it back into melanoma. I talked broadly about genetic testing for cancer susceptibility and what has been going on within melanoma. So most of melanoma genetic testing, up until maybe about the last 10 years, was focused on what I mentioned was the CDKN2A and CDK4 because we knew that existed, and we focused on what we call a rule of three. 3 melanomas in a family, 3 melanomas in an individual, plus or minus pancreatic cancer, and that was the focus, that 2 to 2.5% of patients that had melanoma that were sort of in that super high risk category. As we've been more able to do genetic testing, and we see this in other cancers as well, when we expand that panel and loosen those criteria to a rule of 2, and I'll talk about what that means in a second, we find more individuals with significant genetic changes in those cancer susceptibility genes. And what you can see is that it goes up to about 10 to 15% depending on how you include individuals. And I'll show more of that data in just a minute. And so what I would say is I think we are going to trend more. As we have more genetic information, we will talk more about genetic testing for more individuals. And then the final point is actually is sort of the question of should we go to all patients with melanoma, which they've done in some cancers. And what I would say that is not exactly this question is that we were looking at a large data set from the National Institutes of Health, and we actually looked for, irrespective of cancer status, patients, some had cancer, some didn't, what percentage of individuals had a significant change in one of these cancer susceptibility genes in the general population. And that was about 5%. And so that's actually the pretest probability that we often do for genetic testing, is you want to hit about 5%, and we're hitting that on some level in the general population. I'm not pushing for universal screening, I'll be clear on that, but I think as we get more and more information, I think it's critical to think about how we can do that genetic testing and be proactive for many individuals. So we talked about sort of that CDKN2A, CDK4 story. Now, in the last 10 years, people have begun to chip away and increase the number of genes. So that panel has increased. I talked about sort of 80 or so genes. Some of these genes are actually on that panel, so people have done some very good research finding other high-risk melanoma genes, including related to telomere maintenance, which is a particular part of the chromosome, along with other genes. And most of these are on that panel, and so we've added to that panel. Emerging research from other groups is actually continuing to add new genes. As we are able to do more genetic testing and genetic sequencing with more and more individuals, we can find those rare events that increase your risk for melanoma. So these are some new genes that people have discovered by other groups, not mine. And so we're excited that we can continue to add and chip away at some of these families so that we can add to the genetic understanding of why certain people are at risk. Just to sort of reiterate about this rule of 2, so just briefly sort of on the your left-hand side, this was our experience at the Cleveland Clinic, about 400 patients using this rule of 2, which I'll show in 1 second. About 15% of patients that met criteria for the rule of 2 tested positive for a significant change in the cancer susceptibility gene. 2 critical points about that data. One is the majority of those patients would not have met that rule of 3 criteria, so they would not have been found. And the second point, which I think is also important, is that the majority, I think it was 2/3, of those who tested positive were in genes that were not classically associated with melanoma. So if we had done a melanoma-specific panel, according to rule of 3, we would have missed those patients. The important piece is that then those patients have life-saving measures that they can do for potentially other cancers. So, you can see a lot of genes in there. You see BRCA2, BRCA1. These are genes that we have very good protocols of how to move forward. On the right-hand side is just sort of we looked at other data sets trying to understand, was this a Cleveland Clinic unique experience or did it expand to other centers? So we collaborated with a variety of different groups, and we found that it was somewhere between 10 and 15% of people, depending on the inclusion criteria, had some sort of significant change in a cancer susceptibility gene, markedly higher than we had previously thought. So the rule of 2 that we used is essentially 2 or more primary melanomas, melanoma and 1 other cancer, not including cutaneous squamous cell carcinoma and basal cell carcinoma, which are relatively common in the European ancestry population, along with an age diagnosis less than or equal to 35, which we often see sort of in genetic testing that if you get a cancer at a younger age, it's more likely to be genetic, and then some family history features there as well. So just to refresh before we go into a little bit about treatment and future directions as we're getting to the last few minutes. So we took this All of Us data set that I mentioned before, that it's 400,000 individuals, and we wanted to see if you had a cancer susceptibility gene alteration, were you more likely to get melanoma? Essentially, the blue curve is a carrier of one of those, a significant change in one of those genes. If the curve shifts to the side and down, that means that you're more likely to get melanoma and you're more likely to get it at a younger age. And so the carriers in this of these genetic changes had more melanomas and at a younger age. We broke it down by specific genes. You can see the green is CDKN2A, which was expected. We know that's a very high-risk gene, that they got melanomas at a younger age and more frequently. MITF alterations as well. And the funny thing is, even with this large study, sometimes small changes we do not see as much because we still need larger and larger studies. The other thing is some cancer susceptibility genes don't necessarily make your age diagnosis earlier, it just may be more frequent. So that's sort of concluding that portion. Just a little bit of a teasing about changes in cancer susceptibility genes and how they relate to cancer treatment. So the critical thing here, I know there's 4 graphs there that are reasonably well-sized, but still, the blue curve is the patients that have a significant change in one of those cancer susceptibility genes on immunotherapy, and the red, orange, whatever color you want to call it, are the ones that do not. And what you can see is that the patients in the blue do better on immunotherapy. So there may be some sort of combinatory effect for these changes in cancer susceptibility genes with regards to immunotherapy. So I hope at this point in time there's some evidence that genetics are important in melanoma. So where are we going to go from here? I think it's critical that, we talked about melanoma being super heritable. We want to add to that sort of genetic picture, discover new genes that are relevant, but also simultaneously remind patients that maybe there is a genetic component that was out of their control and guilt maybe is not as critical. If we understand that genetic risk factor for an individual, we can both do high-risk screening measures, but also we can understand molecularly what is going on and target that particular alteration potentially for targeted preventative approaches for those individuals to reduce the risk of melanoma and potentially other cancers. The last thing is, adding to the previous slide, is understanding more genetic risk variants that affect our body that also affect our response to melanoma therapies and melanoma outcome. This is just a paper that was recently published by another group looking at that as well. So I think these are exciting new directions where we can do more and more genetic research because it's easier and cheaper than it once was, and we hope that we can add more patients so that we have power to discover more genetic risk variants that are relevant for patients with melanoma. And so I'll conclude with thanking to the patients that participated in the research, the people that did the research, as well as the funding that supported this research that I presented. And that's the end.